This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Well, welcome to our podcast on primary prevention. And with me today is a very, very good friend, a Canadian colleague, Dr. Martha Gulati, who's editor-in-chief of the American College of Cardiology section of CardioSmart, which is a very, very helpful segment for a patient that is available online. As well, she's president-elect of the American Society for Preventive Cardiology. So, Martha, welcome to MyHeart.net.
Thanks for having me.
Well, although there has been significant improvement in atherosclerotic cardiovascular outcome in the last 2 decades, cardiovascular disease remains the leading cause of morbidity and mortality globally. In the U.S., it's the leading cause of death for people of most racial and ethnic groups. Much of this is actually attributable to suboptimal implementation of prevention strategies and uncontrolled atherosclerotic risk factors in many adults. So what we try to do first is maybe you could try to define for us, Martha, what is primary prevention and how does it compare to primordial prevention as well as secondary prevention?
Yeah, so the 3 types of prevention you just mentioned, primordial is where we're trying to create healthy behaviors to preserve health throughout the lifetime. And these things that often have to do with public health policies as much as behaviors. Things like, for example, reducing smoking in society, or reducing physical inactivity or environmental pollution, because that would benefit everyone and reduce the risk of cardiovascular disease. Secondary prevention is, of course, once you have cardiovascular disease, how do we reduce your risk of future cardiac events? And primary prevention is where you may have risk factors already, but how do we prevent them from progressing towards cardiovascular disease? How do we if we treat them, can we reduce your risk of developing cardiovascular disease? So it's important for people to just understand where we're at and what we're addressing for that particular individual.
So obviously we want to identify patients with sufficient risk to merit treatment and with higher likelihood of benefit, without having any harm for the treatment we want to do. So how do we identify, patients that are more at risk that would really benefit from these treatment for primary prevention?
Yeah, so from our primary prevention guidelines, I think we talked about this last time we spoke, but we talked about the A, B, C, D's, and E's of prevention. And the first one is the A, which is assessing risk. And if we don't know somebody's risk, we can't start our treatment per se for primary prevention. So the way we do it in the United States is the recommended risk equation that we use is the ASCVD risk equation, and ASCVD just stands for atherosclerotic cardiovascular disease. So we're trying to assess your risk for heart disease or stroke. And once we know what that is, we can better make a plan for the individual for what is your individualized approach to preventing heart disease. And it has 2 components to it, of course. The first component is the tenure risk. So knowing in the short term, what is your risk for developing cardiovascular disease, which is important. But I think the lifetime risk is also important, because when you're a young person, we can't actually calculate your 10-year risk for somebody under the age of 40, for example, based on our risk calculator. And so we do need to talk about lifetime risk, because for younger people, they don't fit into that risk equation. And the lifetime risk matters. They might be low risk right now, but if they continue these behaviors, or if they continue to have risk factors present over time, their lifetime risk may be very high. And so it has some caveats to it, the ASCVD risk equation, which maybe you'll ask me about. But in general, it's a good starting point. It's not the ending point, is the way that I tell people. And if it's an app that's available to anyone. Your physician can walk you through it and calculate your risk. But that doesn't mean that as an individual, you can't look or download this app. It's also on the internet, and you can put in your numbers if you know your numbers. One number you'll know for sure is your age. Don't lie to it because it's not going to tell anybody. You'll have to put in your race. You'll put in whether you have specific cardiac risk factors. So if you have hypertension or not, if you're being treated for that, if you have diabetes or not, if you're a smoker. And that's the beginning. You'll put in if you're male or female. But you do need to know your blood pressure, and you do need to know your cholesterol and your total cholesterol and your HDL. And once you have those numbers, you can put them in. So if you don't have them, make sure you get them from your doctor and you can put it in. But it's actually very helpful for you and your healthcare team to put them in together and talk about what it means, because it may be harder for a patient to just look at that number and know, is that good? Is that bad? What do I do about it? It doesn't mean that just because you have a risk that you need medication. For many people, it might be that you just need certain strategies to lower your risk that don't even involve any medications at all. So I really suggest you do it with your healthcare team.
That's a great idea. So I think it's a good place maybe to start the conversation, having the patient and the physician kind of start a conversation on primary prevention. I mean, obviously, it's not perfect. I mean, it doesn't account for family history or certain race. So I think the new guidelines really kind of emphasize the point that obviously this is just the beginning of the discussion, but they mentioned about some risk enhancers. What are those, and how do you apply those in clinical practice?
Yeah, no, I think the risk enhancers are the things that help us for people that are sort of in the intermediate risk range, or even for the lower risk, but to determine if they are truly low risk or truly intermediate risk, and making decisions about whether they need or would benefit from medications or not. And that's where that sort of personalized or precision medicine comes in, is to be asking for more, because you're right, family history isn't in there. And of course we know family history matters. And additionally, things that are specific to women may not be in there. Race, for example, I will tell you, although you put in your race, and the choices when you do this are whether you're white, whether you're Black, or whether you're other. And so other, just to warn you, by default, other, you become white in this risk calculator. So there is certain races that are at risk. Certainly Black people are at greater risk than white people, just in terms of cardiovascular disease, we know that. But South Asians are also at a greater risk, and there's no South Asian risk calculator yet. And actually no other races really studied well enough that we can include them actually in this. So I think that'll probably be fine-tuned as we do more population studies and we have more data. But for now, the risk enhancers are, so the family history of cardiovascular disease, and that's heart disease or stroke. So if a male member in your family, first degree relative, so that means your mother, father, brother, sister, or children, those are the people that are removed by you by 1 degree. If a male in the family under the age of 55 has had early heart disease or stroke, or what we call premature atherosclerotic cardiovascular disease, that's not in your favor. And if a female in your family, again, first degree relative, if they are under the age of 65 with one of the either heart attack or stroke, that's not in your favor. So it starts with the family history. Also, your baseline cholesterol may matter too. That's noted as a risk enhancer. So particularly the LDL, if your LDL is above 160, you're in a different category of risk. And so sometimes primary care physicians won't recognize that, but hopefully by using these risk enhancers, they'll start to get to know that. But if you know your LDL is above 160, you really need to be with a preventive preventive cardiologist to talk about what are the implications of that. The other risk enhancer is something called the metabolic syndrome, and we talked about this before, but I think you shared it nicely, that I always say it's the person whose tummy enters the room before the rest of the person, but it's sort of that typical cluster of risk factors that come together. And these are things like the bigger waist circumference, higher triglycerides, lower HDL, and elevated blood pressure and elevated glucose. And if you have 3 of those risk factors together, you probably have the metabolic syndrome. And all it does is points out to us that you're at greater risk of developing not just diabetes, but heart disease. Somebody who also has chronic kidney disease, that is a risk enhancer. And the more we are learning is that kidney disease is so closely linked to heart disease, and we really shouldn't minimize that is also telling us something unique about that individual. There's other conditions, chronic inflammatory conditions, things like lupus, rheumatoid arthritis, even HIV and AIDS and psoriasis. Those are all inflammation conditions that are, again, pointing that you have a greater degree of inflammation and perhaps a greater risk of heart disease. Sometimes it might be the inflammation, it might be the medications we use, but it really doesn't matter that we haven't identified which one. It just, if you know you have those conditions, those are things that put you in that higher risk category. And then there's some things like we already talked about just briefly, but race and ethnicity, being Black, but being South Asian ancestry, all of that makes you at higher risk. And then for something specific to women, having either premature menopause can put you at a greater risk of developing heart disease. Then there's those things that occur during pregnancy that we call adverse pregnancy outcomes, things like any type of hypertension during pregnancy, but some people might know they've had preeclampsia or eclampsia, which is even worse. That puts you at a greater risk. Preterm delivery puts you at greater risk, and gestational diabetes put you at a greater risk of heart disease. So those are things unique to women. Other things that we also talk about, elevated C-reactive protein, another marker of inflammation. So if you've had that done, it can help us. Elevated Lp(a), that also is an increased risk and often ties a family history and elevated Lp(a). Sometimes that's the reason you check it, but that puts you at a greater risk. Elevated ApoB as well, which is closely linked to your LDL or non-HDL values. And so sometimes your doctor might end up doing that. And even ankle brachial index, which I think is highly underused clinically, but if you have that and that's abnormal, that you're at a higher risk. So those are kind of the laundry list of risk enhancers. They should be in every primary care and cardiologist's office on their wall so that patients understand if you have one of those conditions, maybe that risk calculator that they just did on you doesn't fit for you perfectly, that the next step has to be done to try to determine if you're actually higher risk.
Well, that's great. So there are some people at low risk, and we're going to say, less than 5% risk of cardiovascular event with the next 10 years. And you have the people at very high risk. That means they're greater than 20%, risk of having a cardiovascular event in the next 10 years. And then these risk enhancers really kind of help us in between. I mean, I guess the one that have borderline or intermediate risk, this kind of 5 to 20% range, which is probably where most of the population, are, and particularly for the 40 to 75, age group. So I think that helps a lot. Now, there are some other predictors of risk. I mean, obviously, this is always a good place to start. It's not perfect. Some people have looked at, other predictors, such as looking at ultrasound of the carotid and have determined that if you had a little bit of intimal thickening, it increased your coronary risk. Somehow, if you had some plaque already, it kind of multiplies times 4. If you had carotid stenosis, that's even worse. And sometimes it can help you reclassify. But yeah, I think there's a big endorsement of the calcium score in the new guidelines. And this was based on MESA study. So maybe if you can enlighten us a little bit, Martha, about this calcium score that now is being integrated in the guidelines.
Absolutely. This is where I think for those borderline risk and intermediate risk patients, and particularly if they fall in that category, but also for the people even low risk with a lot of these risk enhancers, it can help us decide, are you reclassified to low risk because you don't have any evidence of plaque formation? Or are you somebody that already has plaque formation? And it helps our patients because I think for a lot of our patients, I get it, a lot of pushback about taking medications if that's what's recommended for you. And sometimes you need a little more proof. And I think that's where coronary artery calcium has really helped us. It's helped with recalcification, but it's also helped a patient appreciate what's going on in their body. So what a coronary artery calcium score is it looks at calcified plaque in the arteries. It doesn't mean that if you have no plaque by a coronary artery calcium score, that it hasn't been calcified. So there is a probability that you might have plaque, but it might be young plaque. But older plaque tells us that some of these risk factors and risk enhancers are accelerating the plaque formation in your arteries. And it's been there for a while because it's been there long enough to be calcified. And this is where this, more and more data, and I agree that a lot of it isn't randomized controlled data, but what we're seeing from these large populations of people that have underwent coronary artery calcium scores is that it helps us decide who's going to go on and develop cardiovascular disease and who is not, and helps us give a group of people a target of who we should be maybe more aggressive with. By reclassifying them as high risk, we can, be more aggressive about their cholesterol lowering strategies and whether we should be treating them. Because to me, once you have coronary artery calcium, to me, you have coronary artery disease. And at that point, we, at least it would make them a high risk person, and we should be more aggressive with them. Whereas somebody else who might have lots of these risk enhancers, but looks like either borderline or even low risk, and you do a coronary artery calcium score, you'd be much more comfortable with saying, okay, let's just work on lifestyle and let's not right now start medication. And I think that's where it's very helpful, especially with all these risk enhancers, because when you start using the risk enhancers as a screening after you do your ASCVD risk, you find most people have one or two of these. Or more, actually, if they're unlucky enough. And so going through that can help us decide what should be the optimal therapy for these patients.
Yeah, this MESA study, to me, I found fascinating. I guess MESA stands for Multi-Ethnic Study of Atherosclerosis. And a study has been going on now for years, and the group at Johns Hopkins is very, very active with this. But they looked at 6,800 asymptomatic men and women from the age of 45 to 84 with 38% white, 28% African-American, 22% Hispanic, and 12%, Asian, mostly Chinese. And it's really amazing to me if you kind of look at the patient groups that they have. They had also the young patient population, the 45 to 54. Of course, most of them, 3/4 of them had calcium score of 0, and they had very, very low event. I mean, it was less than 1% over a period of 10 years, while they had maybe a small group, but 5% of their patient had calcium score greater than 100. And these had a very high rate of event, almost as high as if you had coronary disease. They had like 17% event rate over a period of 10 years. But also what's very interesting, Martha, is also at the end of the spectrum. If you look at the age of 75 to 84, there was 20% of the patient that had a calcium score of 0. which is amazing to me because, you imagine that, yeah, of course, calcium and coronary disease goes up with age, but yet there are some patients that I think you could do some harm with statin or be too aggressive, with aspirin. If they had no evidence of coronary artery disease, you're not going to help them, with preventive, measures that we have. It's not one pill for all, and therefore a very, very nice way to maybe identify a little bit better who's going to benefit more, maybe, or most.
Yeah, and I love the MESA risk calculator, to be honest, because with the MESA risk calculator, if they've had a coronary calcium score, it takes into account the same things that we talked about for the ASCVD risk score, but you put in what their coronary artery calcium score is, and then it either reclassifies them automatically to, whether they're low risk or high risk. And I think the MESA data, in addition to numerous others, but MESA is, from a population standpoint, has been such a learning study for all of us, and just sort of the natural history of what happens to an individual that they get to follow in MESA for numerous years. And that allows us to know really what did these studies mean? Like, what do those findings mean? Because until MESA, we didn't know, like, so if plaque is there, we didn't know, it was always a snapshot in time. Whereas MESA, we get to watch people over time and we see who has cardiac events and who doesn't. And I think that, was very convincing. And I think when the MESA group came out, and there was other people already saying this, but when MESA showed us what was happening to that population, it was very convincing. And I think for people that are trying to figure out, am I at risk, which I know a lot of my patients always is the question, and seeing is believing is what I tell them. And that's why we'll sit down and look at the calcium score together and show them where the plaque is if they found plaque, or if we found no plaque, that we, can have a little celebration. It doesn't mean that not to keep up on the good lifestyle that they're already doing, but to continue it because it's obviously working. And maybe that's someone who doesn't need medication versus somebody with plaque. And I think, I don't know if you remember, but I feel like when I finished fellowship, a lot of people were doing coronary calcium scores, and it was felt like it was a marketing tool, and I got such a bad rap. And the sad part about coronary calcium is, for many states still, you have to pay out of your pocket to get it done. Now it's getting more and more acceptance, and so I do think insurers will come around and start paying for it. But it really, I think it was so biased by what we didn't know at that time. And now I think all of us want our patients to have a coronary calcium score because it helps us guide their therapy. And it's always sad to me when we can't get coverage for it. And then patients, everybody has a different level of income, and so it's usually around $100 to $150 in most cities, but that money can, not everyone can afford it, which is really unfortunate. So I hope one day soon we'll be able to allow that for the people in the groups that really need it.
Well, to this point, Martha, I think I'm wondering if it was the Cleveland Clinic that they did an experiment, and they had a calcium score for free, and they were offering it to the public. And who benefited the most were the women, minority, the one with low socioeconomic, layers of the population that probably would benefit the most. Yeah. So, to your point, I think if you had a very low, inexpensive, calcium score, you could really kind of improve and have a significant impact for primary prevention in overall population everywhere.
Yeah, it's really, of all the things we do in cardiology in terms of cost effectiveness, I would say there's now more and more data showing the cost effectiveness because it isn't very expensive. Of many other studies we do in cardiology, they're very expensive tests, actually.
I have to say that we'll probably have a podcast on cardiac CT and discuss the calcium score, but it's a very easy test to do. It's very, very little radiation. It's about 1 millisievert. It takes about 15 minutes. There's no contrast, there's no needle, nothing. And it's very, very simple and available at multiple places. A couple of things I want to mention about this. I think you mentioned already this primary prevention and the secondary prevention where you want to, prevent, you don't want to have a heart attack. You don't want someone to have bypass surgery. So there's got to be this preclinical disease, these patients that we're missing, between being totally asymptomatic, but they're really progressing, a lot. And Johns Hopkins just published an article in March in Circulation on very high calcium score, and a calcium score greater than 1,000, and really demonstrated that the cardiovascular event and mortality was very high in this group, was as high as someone that had actually coronary artery disease. And basically, if you have a very high calcium score, whether it's 1,000 or whether you're in the 90th percentile, it has a lot of implication. And we, as physicians, we need to be super aggressive and really convincing our patient maybe that they do need, the aspirin, and they do need, the statin. This is the time really to kind of intervene before they have an event, before they have a heart attack. So very, very interesting. Another aspect, we do mention that a lot of times that there is no multi-center study done with a calcium score. But actually, there was one study that I found in 2005, and it was the San Francisco Heart, study that randomized patients according to their calcium score to determine who would benefit from atorvastatin. And by that time, it was like 20 milligram. And it looks like the patients that had calcium score greater than 400 had a 6% benefit over a period of 4 years. So, but you have to dig down to 2005. It's amazing there hasn't been, any more multi-center study, using the calcium score. And finally, there's the calcium score of 0. And what is the warranty of having a calcium score of 0? Obviously, you're not going to be, free for life, but you have very low event as long as you stay at 0. But they do recommend to repeat it every 4 to 5 years, because the patients that change and become greater than 0, they develop, more event as they go. So we shouldn't be complacent. If we do get a calcium score and it's 0, means that, you don't have to follow your healthy lifestyle habit like you mentioned. So I think it's very important to stick to what makes sense, So we've talked about risk, and now I'd like to see if we could address our 4 main primary intervention that we want to discuss. And of course, the first one is the aspirin. And aspirin, as we find out, is not for everybody. So when I grew up in medicine, obviously I came out of medical school in 79 and the 80s, and in 1989. There was the physician health study that enrolled 22,000 male physicians, and they were randomized to aspirin 325 every other day. And it did reduce the myocardial infarction by 44%. There was no reduction in mortality, and there was some question about, increase in hemorrhagic stroke. And now, in the last 3 years, 3 studies come up. We have to wait that long. Can you imagine? 30 years. It's amazing. But now we have 3 new studies. We have ARRIVE, we have Ascent, we have Esprit, and they're telling us something totally different. So, Martha, try to illuminate us a little bit on the situation with aspirin in primary prevention.
Yeah, this is obviously an evolving story, right, from where we were before. And we're used to have this expression, an aspirin a day keeps the doctor away, and no more. So at least not for primary prevention. So again, just to go back one little step, if you have heart disease or you've had a stroke and you've been given aspirin, we're not talking to you. Keep taking it, because that clearly has a benefit. And so just ignore everything else we say. But for primary prevention, for those people who don't have heart disease but have risk factors, and when they're discussing about aspirin need for them, and even if they've been on aspirin, they might want to rediscuss it in light of these 3 studies. So Ascend was a study looking at primary prevention of heart disease and stroke. And these were people who were diabetic, none of whom had atherosclerotic cardiovascular disease. And they actually saw that there was a benefit by using aspirin. And those people who got aspirin, their rate of major adverse cardiovascular events was reduced by 8.5%. The rate was 8.5% compared to about 10% in those people who got placebo. But the problem was they saw more bleeding in those people who got the aspirin compared to those who did not. And the risk of bleeding was greater than the benefit that they got from from taking the aspirin. So then Esprit looked at, these were not just diabetic, these were higher risk, but elderly, above the age of 70 years, or they could be above the age of 65 if they were Black or Hispanic. And they actually saw no reduction in all-cause mortality, no reduction in major adverse cardiovascular events, but a greater risk of bleeding, again, compared to those people who got placebo. ARRIVE was the third trial, and this was men above the age of 55, women above the age of 60. They had to be moderate risk by that risk calculator that we talked about, the moderate 10-year risk, and they had no reduction in major adverse cardiovascular events, but again, an increased risk in GI bleeds, gastrointestinal bleeds. So as a result of those three trials, it changed everything we recommended. It changed the recommendation from the U.S. Preventative Services Task Force guidelines, and also what the ACC and American Heart Association recommends, which was that we don't anymore routinely suggest aspirin for primary prevention in patients. And if we do recommend it, it's going to be in very high risk patients. And so it's really a personalized discussion if you need aspirin personally versus a blanket statement that we used to have where we would say, aspirin for everybody if they're at any risk of heart disease. So, and what I tell patients, if they haven't talked in the last few years about, they think they're on aspirin just from prevention's sake, is to bring it up again with their healthcare team and talk about, do you still think I need it? Because I heard that there's more risk of bleeding. And it's always going to be that balance. Even for the person that's at high risk, we need to talk about what's your risk of bleeding. Because if you have a greater risk of bleeding, I'm never going to put you on aspirin, even if you're at high risk for heart disease, because we'll be meeting in the emergency room if we're lucky with your GI bleed, but some people are not so lucky. They can bleed out very fast and they might not make it to the emergency room. So it's really important for us to know this. And I would say, if you ask why, like you talked about the physician health study, that was observational. And that's why we can't rely on observational studies. These were mostly doctors, mostly male doctors, and they were doing other healthy behaviors. So there was something about them taking aspirin that also they were doing other healthy things. And maybe that's why we saw the benefit. But we can't that sort of gives us a hypothesis, but it isn't a randomized trial like those other trials that we talked about. And you really want to know in trials, does it work the same way? And it is surprising, to your point, why it took us 30 years to get to that. But it was because I think in our community, there were so many other drugs being developed, and there was no pharmaceutical interest really in doing those trials, right? Because aspirin was generic, it's pennies. Nobody was like, okay, we've got that out of the way. Let's study all these other new drugs and show what they do. And I think to some degree, we ignored it. But, it's important that we always ask the questions about the things we're using. And I remember hearing this in medical school, at a point where you think something does something, it's time to think if a new study needs to be done. And I think that we've had a lot of examples like that. And aspirin is one such example, to always question if these things are exactly what we thought they were. What science were they based on? And have we done the right studies? And I think a lot of people are actually asking the right questions now. So I think that's the aspirin story right now. And we've gone, yeah, absolutely. If patients feel confused, they probably feel like it's like coffee. One day coffee's bad for you. Today coffee's good for you. One day aspirin's good for you. Today aspirin's not safe for you. Talk with your doctor. Talk about it individually. Don't ever stop anything without doing this with your doctor, because there may be something you don't know. Maybe you have plaque in your arteries. Maybe you've had a coronary artery calcium score, for example. And if you have a coronary artery calcium score, but you haven't had a cardiac event, but if it's above 100, I pretty much do use aspirin, because there the data is strong that there's a greater benefit. So always communicate with your doctor. If you're thinking, well, they just said this, does that apply to me? Go find out if it applies to you.
Well, they were not perfect studies. They were wanting to enroll higher risk patients. They ended up enrolling a lot of lower risk individual, and there was also a problem with adherence, that was barely 50%. But the point is, I think if you have low risk, aspirin will just increase the risk of bleeding and will not benefit from the cardiovascular standpoint. Now, if you have diabetes or you're at a higher risk, as you mentioned, with elevated calcium score, I think that's a very, very good option, to be on aspirin. And if there's been some bleed in the past, PPIs work very well. And actually, they do, you still see the benefit of cardiovascular event, but you have a lower risk of bleeding in those circumstances. So that's the aspirin. Now let's talk about the blood pressure and who do we treat. So hypertension, accounts for more cardiovascular death than any other risk factors. And the prevalence of blood pressure greater than 130/80 in the US is ginormous. It's about 46%, or over 105 million. It's higher in Blacks, and it increases dramatically with age. So we can see how it has this significant impact treating the blood pressure. So what are the new blood pressure thresholds that we have in the guidelines now, Martha? And what's the evidence that we have that it really works?
Yeah, so now we've defined normal. Normal blood pressure is with the top number, which is known as systolic, being under 120 millimeters of mercury, and the diastolic being under 80 millimeters of mercury. So that's how you're normal. Otherwise, you're not normal anymore. And that was a big change for us. Elevated blood pressure. So we used to have this term pre-hypertension, and we've moved away from it because we really think that was giving a wrong information to patients. So elevated blood pressure is people with a systolic, the top number 120 to 129, and a diastolic still under 80. So if you fall in that, it's elevated. And we can talk about what the indications are about treating at those numbers. But hypertension is now when you're above 130 systolic, and if you're above 80 millimeters of mercury on the diastolic blood pressure. And we have two stages. We have stage 1 and stage 2. Stage 2 is when it's above or equal to 140 systolic and above 90 diastolic. So I think a lot of people thought those last numbers was the number for the diagnosis of hypertension, but we've really shifted it down. And there's different treatment implications based on whether you are high risk for cardiovascular disease or whether you already have cardiovascular disease, in terms of what our goal setting should be for you. Again, you might want to ask me about that, but for everyone who has hypertension, or for everyone that we want to prevent hypertension, regardless, we should be talking about what are the other things you can do to preserve cardiovascular health and reduce your risk of developing hypertension. Because like you said, it's so common, and it is the number one really right now in terms of risk factors present in our society. Hypertension is the most important one, and yet the one that we can treat so effectively, but sadly we do the least good at, just in general. And I'm not blaming the patients, I'm actually blaming the medical community. We are really bad first of all, at checking blood pressure. We're bad at following up on it. We're bad at using our tools in clinic or at home properly. It's just a pet peeve of mine that we just don't, something that should be so simple. And if you think about it, when we were in medical school, or at least when I was in medical school, blood pressure, how do you measure it? It was this, you threw it on your classmate, you showed that you could inflate the cuff, and could you hear the sound? Okay, good, you know how to take blood pressure. Nothing else was taught to me. It was only when I was in practice, when I finished fellowship, that I actually truly learned how to take blood pressure, because I had the honor of working with actually nephrologists, and what my first boss was Henry Black and George Backris, and they were like really anal about how you check blood pressure, and our whole clinic was built around checking blood pressure and having the proper desks and sitting patients nicely, and we used ambulatory blood pressure cuffs like nobody else. And I learned there how important it was to take blood pressure right and to follow up on it. But I think that that's really something we lack, and we should really do a better job. I know patients may not care about that, but I just tell you, there's so much to simple things that we can do for you that we don't do.
Certainly, treating blood pressure really makes a big difference. I mean, we can go to the blood pressure trialists, this meta-analysis, 11 trials, over 64,000 patients. You lower the blood pressure, you decrease cardiac event by 15% in each of the ASCVD groups. I mean, it's really unbelievable. So how do we do that? I mean, obviously there's some non-pharmacological, ways, and there are some medication maybe we could address. Let's get started with the non-pharmacological, because these are very, very powerful ways of lower pressure.
Yeah, I think that those are probably as important as any medication. And I know that not all of them will be present in one individual. So, if you might say, well, I don't have this one, but you might have some of them. So, or things that you can do. So if you need to lose weight, and not everyone needs to lose weight, you don't have to be overweight to have hypertension. I just tell you that I take care of a lot of runners because I'm a runner myself. And then they all get surprised when they hit a certain age, they have hypertension, and they're like, but I run every day. I'm like, okay, but that's just how our bodies are, and we just have to treat it. But if you have some extra weight on you, we know that for every kilogram of weight loss, you can reduce your systolic blood pressure by about 1 millimeter of mercury. So if you need a motivation to lose weight, let me tell you, there should be a motivation, because you can actually reduce your systolic blood pressure pretty effectively. Also, if you don't follow that healthy of a diet plan, the DASH diet, which is, a lot of people think the DASH diet was low sodium. It actually really wasn't. It was a diet rich in fruits, vegetables, whole grains, low-fat dairy products, reduction in your saturated and total fat intake. But that was it. That's what the DASH diet was. And that healthy diet was really powerful and showed that it could reduce systolic blood pressure in somebody who had hypertension by about 11 millimeters of mercury. But even in somebody who's normotensive, you could reduce your blood pressure by about 3 millimeters of mercury. So that's still pretty powerful. And we want to preserve normal blood pressure. So that's why I'm telling you what would happen to somebody who doesn't even have hypertension. Now, if you added to the DASH diet the reduction in sodium or salt intake, so if your sodium intake was to about 1,500 milligrams a day or less, that would reduce your systolic blood pressure by 5 or 6 millimeters of mercury in somebody who had hypertension, and about 2 to 3 millimeters of mercury in somebody who was normotensive. And then if you raised your potassium intake, so if that's the only thing you said you could do, that you like certain foods that are rich in potassium, fine, great. If you can increase it to about 500 milligrams a day, that will lower your systolic blood pressure by about 4 to 5 millimeters of mercury in somebody who already has hypertension, and about 2 millimeters of mercury in somebody who has normal blood pressure. So I hope you're seeing, like, you can add up all these different things depending on what you can do. It doesn't have to be done on day one. You can try with, one thing at a time. Maybe start the DASH diet, then say, can I lower my sodium intake? Can I increase my potassium intake in another month? You can see what a powerful effect these things can have. Now, if you also add into this physical activity, particularly aerobic activity, can reduce your systolic blood pressure by about 5 to 8 millimeters of mercury in somebody who has normal blood pressure, somebody who is hypertensive, and about 2 to 4 millimeters in somebody with normal blood pressure. And then if you add in some resistance training, that can also further lower your blood pressure by about 4 to 5 millimeters of mercury in somebody who has hypertension, and actually 2 to 4 millimeters in somebody who is normotensive as well. That can be reduced. And another thing, I know people like us to say as cardiologists that, you can drink alcohol, but if you have hypertension and you want a really easy way of lowering your blood pressure, is try to reduce your alcohol intake, because alcohol consumption actually raises your blood pressure. And by getting rid of alcohol, your blood pressure in somebody who's hypertensive, it reduces by 4 millimeters of mercury. And by somebody who doesn't have hypertension, it can reduce your blood pressure by about 3 millimeters of mercury. So all of these lifestyle changes are pretty impactful from a hypertensive standpoint, but also for somebody who has normal blood pressure. And I always show this. I actually have a nice table of this in my office because I like people to feel empowered, because actually most people, like we already talked about, hate being on medications. And I'm like, okay, which of these can we do? And which ones are you willing to do? And let's follow the impact of them. It can be very empowering. I've had patients who have sometimes tackled all of them because they really hated the idea of being on medications. So they would do many of these things that they could do in their life, and we would see dramatic falls in blood pressure. So medication is certainly one part of our treatment arm, but not the only part, nor should it ever be. I really don't. Even with somebody who I clearly say, yeah, you need to be on medication, it doesn't come without the lifestyle lecture. Which of these things can we do? Because it is very empowering to know you can control. There's a lot of things we can't control in life, but blood pressure is actually one of them that you have some control over. Or maybe you don't like medications at the higher doses, so maybe we can get you on a lower dose of a medication than something that you maybe you have side effects to when we're at the higher doses.
I think that's such a good point, Martha. There's a study we did, a multi-center study with renal denervation. And the study was positive, which was one of the few that was positive. And the average lowering of blood pressure was 3 millimeters of mercury. And here you're talking about these weight loss and healthy diet, sodium restriction and potassium-rich diet that lower blood pressures by 4 to 5 to even 10 millimeters of mercury. I mean, this is an incredible, impact and very, very significant. Now, there are some patients with hypertension that are at higher risk. And these are the ones that you want to start medication probably earlier. What are those patients, Martha?
Well, certainly the people that need hard to ignore the need for medication is people who already have cardiovascular disease. I mean, if they already have cardiovascular disease or, heart attack or prior stroke, there's little room. And there are also the people that when we classified this new stage 1 hypertension, that we want to get their blood pressure actually lower. And we have a lower threshold for starting medications too. Doesn't mean, again, to ignore these other things, strategies that they can do, but we want to make sure we're treating them. And then, of course, people with chronic kidney disease is another group that we don't want to ignore. Diabetics, these are those higher risk people that we were already talking about. And then also people who have a 10-year ASCVD risk score that's above 10%. That's, again, our high risk for cardiovascular disease, even if they don't even have an event. they're the ones that we've got to keep their blood pressure lower. So if they're, if they're in the elevated blood pressure, I may just talk about lifestyle, but if they're already at stage 1, we would add to all those lifestyle things, we would add medications. And with our new guidelines, we've also pointed out the fact that the majority of patients, really, it's ineffective to just use one medication alone for them. And we often will need 2 medications, and we shouldn't be so scared. I think this is more a recommendation for doctors to not be so scared to use 2 medications up front. Because if we can use maybe a lower dose of 2, we might get, patients might better able to tolerate those medications in combination rather than a single dose, higher dose pill that they may not tolerate as well. So I think it's changed our community to treat people differently, but also hopefully have helped patients be more compliant with medications. Because I think from a patient's perspective, none of us like side effects. And some of them are really make you not want to use the medication. And so if we can find what's right for you, I think the other thing for patients to know is that, yes, blood pressure medications may have side effects, but we have so many medications now that we can find for you one that doesn't affect you or your quality of life. So don't give up if you've been on one medication and you decided on your own to stop it because of the side effect. Don't ever do that. Blood pressure medication needs to be taken, but you must tell your doctor about the side effects you're having, because they can change it and give you a medication that would work for you. And sometimes it's trial and error. I'll just be honest. There's certain patients I can give them the first drug and they have no problem. And then you can be like my father and have every side effect until we find the right one. And, and you learn, us as physicians, we learn we don't have a magic genetic test to say, oh, on this patient, they're going to get leg swelling, or this patient's going to get a cough, but we're getting closer and closer. And one day we will be able to just take a little bit of your blood and be able to know what's the right medication for you. But right now you got to let us do some trial and error, but always tell your doctor about what side effects you're having, so that, because don't assume you have to live with those side effects. We have so many drugs out there that we can try on you and try to minimize, and strategies that we can use to help you get on the right medication. Sorry.
Good. I had just a patient last month actually that had stage 2 hypertension, 140. Over 80, and I started her. She was already on something, and I gave her another medication, and also we talked about the diet, and she said I really could do without the meat. And of course, her husband looked at me funny. I said, well, why don't we try that? And she went vegan. And a month later, I had to stop the medication that I had started, just because now her blood pressure. She was feeling a little bit lightheaded and dizzy, in the blood pressure. She was registering blood pressures of 95 and 100, systolic. And I came off my medication just because of the lifestyle that what she did. So, I mean, it's obviously
your favorite thing. Isn't that the favorite thing to happen? I love when patients really just, go all in, and they change it, and so much so that you have to stop things you started. It makes me so happy. I'm so excited when that does happen. Or even reducing medications. It makes me happy.
Yeah, but very good point. I think patients with chronic kidney disease, patients with diabetes, and probably patients with a high calcium score, greater than 100, if they're in that risk profile of, 5 to 15%, I think we should kind of start them early, or intensify, their treatment. So we talked about aspirin, we've talked about blood pressure, and let's talk about cholesterol. Obviously, that's a big one. And knowing, when to treat, who to treat. So there's really, in the guidelines, there's really kind of 2 categories of patient that we've got to start, treatment, right away. And then maybe we'll talk about the third overall population category, which is, kind of using the risk stratification of the guidelines. But really comes to mind first the familial hypertension, and then we'll talk about, the high cholesterol and diabetes. So let's talk about FH, for a while. I mean, I guess for us, we see, patients with very, very high cholesterol. That's LDL greater than than 190. We see the heterozygotes one. The homozygous, I guess the pediatricians see those because they develop atherosclerosis in their teens. I mean, that is such an incredible risk factor, FH.
Yeah, FH, and that's familial hypercholesterolemia. And, this is a genetic disorder. And I actually wish that they were more identified in the pediatrician's office, but I don't actually think that's entirely true. I don't think that pediatricians are actually following the guidelines to check cholesterol the way that we recommend. And there are clear guidelines that every child should have their cholesterol checked at least once to know if they fall outside of this category. And certainly in those people with a family history of premature heart disease, but we don't see it happening. And we even see it when we identify an adult with FH and we tell them your children need to be screened. And then they'll come back and say, well, the pediatrician told me they don't need it. And so now I just give their children an order to get their cholesterol checked. And if it's fine, okay, that's great, but at least they get it done. But yes, ideally, that's where it would be identified. And sorry, I got sidetracked. So now I forget what question you asked me about them, but go ahead, please ask me again.
Well, we know that I think we miss those patients, the patients with familial hypercholesterolemia. You get someone admitted for one reason or another, and they draw some cholesterol, and you get an LDL of 200, and they say, oh, your cholesterol is high. But, I think we miss those patients because the cardiovascular disease, it has such an impact, this high cholesterol. I mean, basically, in men, it ages you 10 to 20 years. And in women, it ages a person 20 to 30 years. It gives you, basically, if you're 20, it gives you a heart of a 40 or 50-year-old. I mean, it's tremendously impacted.
Yeah. And, this is where first of all, knowing your family history really helps us. Both did that first degree relative have heart disease, but how old were they? And, I told you having a male relative before the age of 55 and a female relative before 65, but I still want to know even their age. I want to know if they were really, really young in their 20s and 30s, because it heightens at least our thought process. Could you have FH? FH is a genetic disorder. You may carry one of the genes or two of the genes. If you carry one of the genes, you're at high risk. But if you carry two of the genes, you're at very high. Well, you'll have heart disease. And so the one that carries the two bad genes, they're homozygous FH is what we call it. And they have these LDL cholesterols that are extremely high. And you're right, we often meet these very young people in the cath lab. And I took care of a few of these because in our lipid clinic, I had a 22-year-old. He had already had 4 myocardial infarctions by that point. And, it was a lifelong treatment since age 14. I think he was diagnosed, although he clearly had signs before that. And it's a really devastating disease, but yet a disease that we have so many great medications now to treat. Heterozygous FH is much more common. And this is where they usually have one bad gene that really does not help let them metabolize their LDL cholesterol normally. So usually the easiest way is when they get a cholesterol checked. If they're a kid, we'll see their LDL be above 160, and that is not normal for children. And if they have an LDL above 190 when they're an adult, that is not normal. And that should heighten our awareness. But yet there's so many people walking around with those LDLs who have never been told that they have FH. And they don't know, just like that tells us not only their risk, but like we said, for their family, they should talk with their siblings. They should talk with their children, make sure their children have been screened. It doesn't matter how old those kids are, because sometimes they'll be identified even in their 40s and 50s, and their kids might be grown up. But it's important that they share this information, because they may have this genetic defect where they just have an abnormal LDL level. And yet again, the point is we have so many new medications now. At one point we didn't. We just really had, I'd say essentially statins and a few other drugs that didn't actually have outcome evidence. And even with statins alone, we couldn't get their LDL where we needed it to be. Now we have some pretty powerful medications and some new ones on the horizon that are hopefully going to change this. But the key is diagnosis. And if we don't know that you have it, and if somebody isn't addressing it or sending you to a lipid specialist, then we will always suffer from the lack of awareness killing you rather than something that we can do for you.
Yeah, definitely. So, this is the first category of patient that really need high intensity statin. No doubt about that. I mean, the evidence is there. A second group with high cholesterol are the diabetics. I mean, I think if you have diabetes and if you have high cholesterol, it's almost like you have coronary artery disease proven otherwise, and they too require a high intensity statin. I mean, evidence is everywhere that you decrease coronary events, you decrease stroke, you decrease the need for PCI or coronary intervention. We could always consider the risk enhancers. So how long have you had diabetes, and so forth? Do you have proteinuria? How long have you been using insulin and so forth? So, I mean, that no doubt about that. But now we have the overall population, and this is where I think the ASCVD risk and that risk app and the calcium score can really help us identify patients with sufficient risk to merit treatment, and particularly with a high likelihood of net benefit. So, I mean, tell us about this, what the guidelines tell us. I mean, we have this patient population between 40 and 75 years old, an LDL that is between 70 and 189, I guess, otherwise they're FH. How do we classify, how do we treat these patients, Martha?
Yeah, so if, like we said, the high risk group, let's clearly talk about statins first. And we want to get your LDL lowered by at least 50%. But then now we've actually even instilled LDL goals, and that, if we're not getting your LDL under 70, then there's other medications to initiate. If you're that intermediate risk group or that borderline risk group, like we talked about, or you have a coronary calcium score that somehow moved your risk stratified, or those risk enhancers, if you weren't lucky enough to get a coronary calcium score, but you have plenty of those risk enhancers, you might be in that intermediate risk group. So we certainly at that point, if you're in the intermediate risk group, at least then you should be on moderate intensity statin. And we want to get your LDL lowered somewhere between 30 to 50% LDL reduction it's actually a class 1 recommendation if you're in the intermediate risk group. So we should be doing that. And then if you're in that borderline risk group and you don't have additional risk enhancers, you may at least enter the discussion. Where do you fall? Should we use a moderately intense statin therapy? It's certainly not wrong. Or maybe we do a coronary calcium score in that case. And just if there's no coronary artery calcium, maybe we hold off on medical therapy, but we keep a close follow-up on these risk factors. And every year you need to have your ASCVD risk score calibrated, because of course we age, and so our risk goes up and our risk factors change over time. If you're low risk, I don't think that there's a role for statin therapy in that group. But lifestyle needs to still be part of the therapy, that we start talking about it, what's going to preserve you as low risk. It's not static. Nothing about our life, unfortunately, is static. As we age, some things get worse. Hypertension your blood pressure can get higher, and it's part of your ASCVD risk. And again, that's something that sometimes can be lifestyle, but is also a part of our aging. Cholesterol can get worse, again, based on lifestyle and sometimes genetics, and diabetes as well. So all those things enter your risk score if they're changing, guess what? Your ASCVD risk score is changing. So it isn't a one and done type of deal. And again, those risk enhancers may appear as well. Like some things don't change, like your ethnicity obviously doesn't change, but whether you have kidney disease or not might change, whether you got pregnant and had some of these adverse pregnancy outcomes, whether you got diagnosed with those inflammatory conditions we talked about, or somebody did blood work and saw some markers that were elevated that they didn't do before. Again, that's why it's so important that this is an annual assessment.
So low risk, less than 5%, lifestyle, healthy lifestyle. High risk, greater than 20% lifestyle and at least moderate intensity of statin. And this intermediate group, the borderline and intermediate between the 5 and 20%, we try to maybe personalize it according to their risk enhancers or even the calcium score. Because, this is where you have to make the decision with the patient to go on. Obviously you do the lifestyle, but do you go on the statin or not? And some patients have gone on the statin, but they've had side effect. They're hurting all over. They're not so sure they want to take it. And this is where I think the calcium score, can really help. I have a patient, he's 63, very, very healthy. He was an incredible swimmer. His blood pressure was a little bit high at 140, and his cholesterol was also high with an LDL of 140, but very, very healthy and had problem with the statin. In the past, it was kind of hurting him. And I did a calcium score and it measured at 182. And what's interesting is you can go in the app and you can look at obviously the calcium score helps you prevent your coronary event. And it can actually calculate the age of your coronary arteries. And I looked at him and I kind of looked at this and we went in the app together. And I said, despite the fact you're 63, because of your calcium score, you have the coronaries of someone who's 77 years old. And he didn't like that too much, because he's a physician. I mean, he's working out, he's healthy, but, he could see that really it gave him a different perspective and maybe an incentive, to put up maybe with some of the aches and pain and start a statin. So I think it's important to have these discussions, and these tools are very, very helpful to, discuss and personalize medicine to each patient. It could have happened the other way as well. I mean, it could have been an intermediate risk and a calcium score of 0, where there would be really very little benefit, for the statin. So it's kind of interesting. But statin do work. I mean, we have like several trials with primary prevention. We have the mega trial, with pravastatin. We have the ABSCAP, TEXCAPS. Seems like such a long time ago, lovastatin. And finally, the more recent one, Jupiter, and the use of rosuvastatin, truly showing not only a reduction of LDL of up to 50% with rosuvastatin, but your risk reduction up to 44%. Very dramatic. Well, we have one, to talk about at the end, and it's with the diabetes in patients that have diabetes or A1C greater than 6.5. And the reason why it's so important is that it's so prevalent. I mean, we have 12% of the US population that have diabetes, 90 to 95% with type 2 diabetes. That's almost 28 million individuals. In addition, we have a third of the population that have pre-diabetes. I mean, now you're reaching numbers of 76 million people. And it's so heavily influenced by dietary pattern as well as your activity and your body weight. You can have such an impact in patients that have, diabetes in primary prevention.
Yeah, the diabetes is becoming a real issue actually all over the world now, and just a lot to do with both what we're eating and the weight that we're keeping on. And so, it is a big issue. And I think this is where, everything is, as you probably have the listeners have heard is that, diet is a big part of what we need to tackle to reduce cardiovascular disease. And so it goes without saying, everyone with diabetes or pre-diabetes or at risk for diabetes should have a discussion about diet. And I wish we had more medical schools teaching doctors about diet, because I think this is where one of our big lacking. We say eat well, but we don't tell our patients how to eat well. Eat more plants is a simple rule, though, that I would tell you. Even if you like meat, I'm not telling you all have to go without meat, but try to eat more plants is a simple way of improving your diet. So that can be, because so much of our American diet is processed food, fried food, high fat food, a lot of meat. And a lot of patients of mine don't think that they can actually have a meal without meat. And so one of the big things we try to do is teach them how to create really lovely, wonderful, and filling meals that don't involve meat, just so they have that in their repertoire of things that they realize that they can enjoy. And activity, of course, is another part of what everyone should be doing, but even more so somebody with diabetes or pre-diabetes. And then with diabetes, we already touched on this, that a lot of the other risk factors are present. So we have to treat those as well. But we also have medications for people with diabetes that are really important as well. But just if I could just focus a little bit on lifestyle changes, just so that people know, why do we recommend them? It's not just to make your blood sugar better, although that's part of it. We had this very big study all over North America. It was taking place when I was a medical student, and it's still ongoing, the diabetes prevention program. And it took people that were at risk for diabetes, and they randomized them to lifestyle changes, or the other arm was lifestyle changes plus something called metformin, which is a medication. And then another arm was just placebo. They didn't get any of these things. And they found that the two groups that got lifestyle changes or lifestyle changes plus metformin, they had a significant reduction in the occurrence of diabetes. These were people at risk for diabetes. And they had a much lower risk, almost by 58% lower risk of developing diabetes compared to the placebo arm. And that's pretty powerful if you think about our society. So many of us are at risk for diabetes. It isn't always just about the weight. There's things we're eating for different cultures where it doesn't even look like they're fat, but where they carry fat tissue in their body in a different way. And so, that's why we talk about waist circumference too, that sort of tells us that you carry fat, like you're more apple shape versus pear shape is a simple way of talking about it. So many people are like that. And that's where we want to, just the power of lifestyle was what the diabetes prevention program showed, which is why if you're a diabetic, dietary referrals is actually covered based on this study showing just the powerful effect of it. And so I think that we can't underestimate that, in addition to the amazing therapies we have now. Metformin is one of the therapies we do use for people who are diabetic, and it is a good medication, and it actually can reduce the occurrence, as I said, of diabetes, but reduce the blood sugar, particularly something we call the hemoglobin A1C that we follow. And currently it's still within our first lines of therapy in the US. Although I will tell you, I think the European guidelines is not, depending on if they already have risk for heart disease or already have heart failure, they're actually moving away and moving right away to that option of starting an SGLT2 inhibitor, which is a pretty powerful drug as well. That we have now in our arsenal. So the SGLT2 inhibitors, probably people see a lot of commercials for these. They end with the word Flozin on the end of the name. But what they've shown is in people who already have, for example, the way they were studied initially, I should start with that if you had diabetes and you were given these drugs, not only did they lower your blood sugar, or the hemoglobin A1C, but they saw that there was a reduction in weight, a reduction in blood pressure, a reduction, though, in heart failure hospitalizations and a reduction in cardiovascular deaths, which we had never seen within any of these drugs we had for diabetics. So powerful that this drug got studied in our heart failure patients. And we saw that they were less likely to go on and have cardiac events as well. And it turned out it didn't even matter if they were diabetic or non-diabetic. And in those heart failure studies, we were less likely, those patients who were on this medication were less likely to even develop diabetes compared to the group that was in the placebo arm. And then we've shown in the last year, these drugs have reduced progression of kidney disease. So we're really becoming, I will say, in the cardiology community, we should be becoming more pro SGLT2 inhibitors or, the Flozin drugs, whatever you want to call them. Those drugs are really a game changer now. And I think maybe in time they'll change to be first line therapy because they actually have strong outcome data in a way that some of the other medications we are using don't have. But, I think it really, we'll see with time. I don't want to say things that aren't yet guideline directed, but I think, cardiology is working closely with our endocrinology folks, closely now with our nephrology folks, because we all have this drug in common and we should start using it because I think it's going to be a game changer. But at the same point, I want people who have diabetes to ask their doctors, should they be on this drug? But I also want people with heart disease to ask, should they be on this drug specifically? But I also don't want you to ignore the lifestyle part of the equation because what we eat really does matter. We're learning that more than ever. You can't outrun a bad diet. Being physically active is part of it, but really what we're eating in the US is really killing us. And actually, it's not even the US, it's all over the world. We're seeing this in developing countries that in the past didn't have these issues because they didn't have fast food and the same kind of sort of refined diet that we have. Now they're sharing, the whole world's going global. So they have McDonald's like we have McDonald's, or they have fast food on every corner like we have fast food on every corner. And it's changing the weight of the entire world, and it's changing the diabetes epidemic. So we have a lot to do in this space. And diabetes, people with diabetes should not feel alone. So many people are joining you on that table. But the great part is that we have new medications and maybe we can change this trajectory.
That's a very good point. As the guideline do mention metformin as first line, but, very quickly moving into SGLT2 inhibitors and GL, and also the glucagon, receptor agonist. There's a problem that these medications are so expensive. But, hopefully with more and more competition, they will come down in price and become more, affordable for our patients. Obviously, you're going to be, we talked about aspirin, we talked about blood pressure, cholesterol, and diabetes, all the primary prevention that was mostly targeting the population of 40 to 75. And I know you're president-elect of this American Society for Preventive Cardiology, Martha, and I wish there could be more effort to really address younger patient population, the 20-year-old, the 30-year-old. We know it seems like when we do a calcium score and it's 1,000, I feel like we've missed the boat. Already we're into secondary prevention. How do we actually kind of move the needle to address, younger population? And the second thing is a 10-year risk is not a very long, we live a lot longer than this. I wish we could establish or look at our risk on a scale of 20 to 30 year risk, as we live longer. And
I think it's a changing environment, and we need on both ends of the spectrum to be more inclusive in our trials. Part of the reason that our risk score doesn't work in older or younger people is that we didn't study them, and this is really even an issue about statins and hypertension trials. We have more and more trials that, like the SPRINT study, definitely included an older arm, but it didn't include, in my opinion, enough older women, and they're the ones who live the longest. So we need to be better in our trial design at looking at both ends of the spectrum, because we do need to know how these things affect long term. And I would say, again, I'm somebody who focuses heavily on women, and these young women who have these adverse pregnancy outcomes. We probably should talk another time all about women, but when we talk about these young women who have them, they're young, right? Because they're pregnant. And when do they go on and have future cardiovascular events? I'm not telling you that they have future cardiovascular events when they're 60 and 70. No, their risk is elevated in the next 10 years. So think about it. A pregnant woman, so she's 24 or even 30, 10 years from there, she's still a very young woman. She still doesn't really fit into that risk equation. How do we identify them? What should we be doing with them? And how should we be lowering the risk? We don't fully have those answers right now. And it puts us, at in a harm some way, because we aren't really sure to what to tell these women. A lot of us see those women and we tell them they're at greater risk. We work on lifestyle with them. We don't know, should they have certain studies done ahead of time? Would they benefit from a statin? We've had a recent paper that came out that showed for young pregnant women who had preeclampsia, they had more coronary artery calcium. And so there might be an indication to do a coronary artery calcium score in these women at younger ages than the current guidelines recommend. But again, by excluding women and excluding younger people and by excluding older people, we won't have these answers. And I think that needs to be a priority, that we start asking. Just like I always ask in every study, the first thing I look at is percent female, because I want to know, does it apply to my patients? But we should be looking at, how many 80-year-old and plus are enrolled in this study, as we are living longer? Americans aren't living longer, but Canadians are living longer. But, in general, let's all try to get our countries to live longer. But, and then for younger people, what do? We need more studies there. So I think that's really where our gaps are. Our gaps are also in our more diverse populations. We need more studies of people of different ethnicities and racial backgrounds. And I think that's where we as a society should be thinking about, where do we invest our research dollars? Our NIH needs to put these as priorities so we know more about everyone. Because if we are a society that's going to live longer and we want to preserve health, we don't want to spend all our money at the end of life. Let's spend more money up front so that people can live healthy lives and preserve health. That's what I think our priorities as a society should be.
Well, that's a very good point. I like your idea of the calcium score. If you look at someone in the 90th percentile that's 70 years old, with a calcium score of 1,300. If you kind of go down at 50 years old, their calcium score in the 90th percentile was 110. At 40 years old, it was 10. Yeah. And what is it, at 30 or 20? You're talking about, people that don't have very high calcium score, but the fact that the calcium score is not zero really identifies, someone that it potentially can develop the risk and develop atherosclerosis early on. The group at Johns Hopkins did a study in individuals of 20 to 30 years old. And if you had one risk factor, the risk, your calcium score was greater than zero in about 10%. If you had three risk factors, that calcium score greater than zero was present in about 35% of individuals. I mean, these are 20 to 30-year-old. We know that atherosclerosis develops, early on, and it's for us to be able to detect it early on and maybe intervene early on. Certainly, healthy lifestyle should be for everyone, but there may be some others that are more at risk where a intervention could be appropriate. Well, actually, Martha, I think this has been really enlightening. It was great to talk about primary prevention. It's so important, for our patients, because we can prevent coronary artery disease in about 80% of our patients just by doing healthy lifestyle and primary prevention. And what we want to prevent the heart attacks and prevent the need for stents and coronary artery surgery. I think there are so many ways to detect disease as well as to treat disease that makes sense for a lot of our patients.
Yep, I agree with you. I mean, we're seeing that uptick with the increase in mortality from cardiovascular disease in the U.S. for the past, 4 or 5 years now in both men and women. And it is really concerning. So I think we have a lot of work to do in our preventive efforts. And I think this is where we all need to focus, whether it's primary care physicians, whether it's cardiologists, we all have our work cut out ahead of us.
Well, thank you very much, Martha. Everything you want to know about primary prevention with Martha Gulati. Thank you very much for your time. I know we were very lengthy, but there was so much to discuss.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.